Good evening, friends. My job is to talk on the hemodynamics of mitral stenosis, implications for balloon mitral valvotomy. The advent of 2D echo and Inouye method of balloon dilatation has really revolutionized the management of mitral stenosis. And therefore, many experts in this hall and this meeting may think are quite capable of performing BMV even without performing a detailed hemodynamic study. They could even do without measuring the malvaria. But for the vast majority of people, and for many patients, accurate determination of hemodynamics becomes essential, not only to decide the need for balloon mitral valvotomy, also to know when not to do it, and finally to recognize some complications and fallacies. So the next 10 or 15 minutes, I'm going to show you a series of real-life examples which should convince you that accurate measurement of hemodynamics still has a useful role in doing balloon mitral valvotomy. This is familiar to all of you. The American Heart Association lays emphasis on non-invasive diagnosis and assessment of mitral valve, and the severity is graded mainly on valve area, symptoms, and the diastolic pressure half time. In fact, the hemodynamic doesn't have a role in this grading. However, before you do balloon mitral valvotomy, you always enter the LA and the LV and you record the pressures, and this shows the difference between a normal person and a mitral stenosis. In the normal individual, the left ventricular end diastolic pressure and the left atrial pressure are equal. There is no gradient at end diastole between the left atrium and the left ventricle. There may be a small gradient in the early part of diastole. This is partly due to a rapid flow in the initial part of the diastole, as well as part of it is an artifact due to the fluid-filled catheter, which shows as an exaggerated downward dip in the LV diastolic pressure. On the left-hand side, you see a simultaneous tracing of a classical textbook picture of mitral stenosis. The left atrial pressure is elevated, you can see. You can see that there is a shaded area black between the LA pressure and the LV pressure, and the difference continues all the way to end diastole, where the A wave is bisected by the upstroke, sharp upstroke of the LV systolic upstroke. Now, the important part here is there are many gradients. You could measure the gradient at end diastole, which often shows by the sharp upstroke or by the vertical line drawn from the R wave. You could also measure the mean gradient, which represents the area of the total shaded area. One important, this is a very important diagram for exam-going students. Now, one important question always asked is which wave is prominent in the left atrium in mitral stenosis, and the very common answer I get is A wave. Even in mitral stenosis, the V wave remains prominent because V wave is the diastolic filling wave of the left. The atrium is filling during the V wave and therefore during systole, and the V wave still remains prominent because the mitral valve is obstructed and is not draining, and the LA is non-compliant. The height of the V wave really depends upon the compliance of the left atrium. Now note the slope of the fall in the LA pressure. It's gradual in the presence of mitral stenosis as compared to a normal rate of flow on the right-hand side where it falls sharply. That is a Y descent. Now, in the cath lab, we are more comfortable with grading mitral stenosis by valve area. That's a very cumbersome method of applying Garland's formula. More often, the mitral valve gradient and the mean gradient is what we easily identify with, and they are classified between mild, moderate, and severe as shown here. PA pressure is a useful surrogate for the severity of mitral stenosis because severe mitral obstruction invariably produces back pressure. Mind you, when the LA pressure rises to about 20 or 25 levels, that's called the pulmonary edema level, the PA pressure rises proportionately. But beyond that, the LA pressure doesn't rise, even if the mitral stenosis becomes more severe. Then what you have is reactive arterial pulmonary arterial hypertension, where the PA pressure often rises out of proportion to LA pressure, and there often is a site of second level block. One level of block is the mitral stenosis, the second level of block is the arterioles of the pulmonary vasculature, and therefore, when that happens, you may often find that the patient becomes less symptomatic from pulmonary dyspnea and pulmonary edema, but he may become more symptomatic from right heart failure and tiredness because the right heart output falls and the amount of pulmonary venous congestion decreases. Now, this is an important formula for students again. The mitral valve area is calculated by Garland's formula, and the factors which go into it are the cardiac output, which is the numerator, and the denominator is mainly mainly the gradient across the mitral valve, and the flow across the mitral valve, which depends upon the cardiac output and the heart rate. Of course, any increase in the cardiac output will increase the gradient. Any increase in the heart rate will reduce the diastolic time available period for the diastolic filling and will increase the gradient. It's often cumbersome to measure the mitral valve area while you're doing a BMV, and we often go by the easier method value of mean gradient. But please remember that the mitral valve gradient is influenced by, with a given mitral valve area, it's influenced by either the cardiac output or the heart rate. Now, here are two cases. The first one is in sinus rhythm, and you can see that the gradient represented by the shaded area increases markedly when the heart rate goes up in the left-hand panel. On the other side is shown a patient in atrial fibrillation where varying RR intervals and the cycles with a short RR interval shows a distinctly increased gradient. Therefore, the gradients have to be interpreted in the light of the heart rate. Now, here is a case, a 32-year-old male, quite symptomatic. He improved with diuretics, but dyspnea was replaced by fatigue and inability to work. He had tight mitral stenosis as measured by echocardiogram. It was a pliable valve, and he was planned for balloon mitral valvotomy. When he was taken to the cath lab, the operator found that the gradient was only 8 millimeters. That was quite unexpected. He expected very tight mitral stenosis, and he expected a large gradient. The pulmonary arterial wedge pressure was only 18. What could be the reason? One reason could have been that he was on diuretics till that morning, and he was over-diuresed. The other reason could have been he has developed severe pulmonary arterial disease, which is protecting the LA vascular bed, and that along with diuretics, with a low cardiac output, is protecting the lung. So what do you do in such a situation? This data is discrepant with what you got on non-invasive data. So you subject him to some method of increasing the cardiac output. You could give him a fluid load, but more often what you do is you ask him to do simple, mild exercise on the table. Now this is what happened when you did exercise. The same patient who had a mitral valve gradient of 8 and a PA wedge pressure of 18, it went up to 29 gradient and a PA wedge pressure of 20, and mitral stenosis is much more clearly obvious. So exercise has a role in demonstrating significant mitral stenosis. Here is a 54-year-old lady, quite symptomatic like the last patient. She also improved with diuretics. She was having tiredness, and she has mitral stenosis. But the valve area calculated on her echo was 1.9 centimeters square. Again, the valve was pliable. So does she need mitral valvotomy? A cath showed that the wedge pressure was only 13. So the next step would be to do a maneuver to increase the cardiac output. Look what happened. The wedge pressure increased from 13 to 41. But then the LV-EDP also went up, and the LV-EDP and the wedge pressure remains equal. So this patient has a high wedge pressure. She may have mitral stenosis on echocardiography, but her symptoms are not due to the gradient. The symptoms are because she probably has some LV compliance problem. She has some left-sided muscle problem, but symptoms are not due to mitral stenosis. So the high wedge pressure could be due to reasons other than mitral stenosis. Here is a 60-year-old man who's going up for coronary studies. He has a calcific mitral annulus. when the wedge pressure was recorded, it showed a gradient of 15. You can see that there is a distinct separation between the wedge pressure tracing and the LV-EDP. However, the tracing appears to converge towards end diastole. So, do we pay attention to this? Is it mitral stenosis? So, the operator was smart. He put a catheter into the LA through the septum and measured the LA pressure. He found that the LA to LV gradient was only 6 millimeters. Why is it discrepancy? The PA wedge pressure tends to exaggerate the level of LA pressure because there is a phase shift. The PA wedge pressure may overestimate LA pressure because there is a phase shift, and I'll show you what I mean by that. When you superimpose LA and PA wedge pressure on top of each other, you find that the PA wedge pressure is somewhat delayed, the upstroke is delayed, the descent is delayed, and you have a large area between the two curves which appears as a diastolic gradient between LA and LV. Now, when you record a transmitral gradient, this is what happens. In the first tracing here, the V wave is falling after the descending limb of the LV pressure curve, and you get a larger gradient because of this area. Can I have a pointer? See, this area, this gap appears as an increased mean diastolic gradient. Whereas when you record LA pressure, this LA pressure superimposes well on the descending limb, and this gradient is easily is correctly estimated. So PA wedge pressure can overestimate LA pressure. Here is an elderly person again who had elevated wedge pressures. It was 38. But again, and there was a distinct gap between the PA wedge pressure and the LV diastolic gradient. It looks like there is a mitral gradient. Then it was found that this was recognized on the bedside by a thermodilution catheter. Now, you know, thermodilution catheters are often small bore, 3 French, 4 French, and the waveform is not good. When the patient was taken to a cath lab and a regular end hole 7 French catheter was inserted, we found that the PA wedge pressure was only 18, and in fact there was no gradient between the wedge pressure and this thing. So the message here is the conventional method of PA wedge measurement is the right way. That is, a large bore end hole catheter has to be passed into the pulmonary artery. It has to pass out well into the periphery of the lung. The wedge position has to be confirmed by the waveform, by the relative immobility of the catheter tip, by drawing a sample and showing that the sample is fully saturated. Only if all the criteria of wedge tracing is satisfied, you accept the tracing as a pulmonary arterial wedge pressure. So there are numerous errors in measuring pressures, and one must remember there are zero errors, there are calibration errors. When you are comparing two transducers, and you will find that the two transducers are giving different reading, and it's a good idea always to switch transducers, and you see that the same patient has got different pressure mean gradient when you switch the transducers around. Very important to pay attention to all these minor points before you interpret the pressure tracing. Another important point is if you are trying to calculate valve area, the method of cardiac output measurement has to be remembered that thermodilution, the fixed method measures only the forward flow, and therefore it does not take into account the flow which occurs during mitral regurgitation. Now here is a patient who has severe mitral stenosis and it has been dilated, but you still have a small gradient at end diastole. So when do we stop dilating? Is this enough? Now there is no definitely correct method of assessing the balloon size. Different people have used different ways. The most commonly used one is in relation to the height divided by 10. Other people have used balloon body surface area, measurement of annulus in the apical two-chamber view. But there is no single correct method. And then when you start dilating it, when do you stop? Again, there is no guideline. And what is currently recommended is, I borrowed this figure from the website, now is graded dilatation. And that's where hemodynamics plays its most important role. You may measure the annulus by height or by body surface area, but you always start with a smaller than predicted balloon size and go up gradually, each time measuring the gradient and till you abolish the gradient or you satisfy one of the other criteria as shown here. You stop when the gradient is abolished or nearly abolished as shown here, when you have an adequate valve area in mitral 2D echo, or if there is any worsening of MR. So hemodynamics and echo assessment of MR both have an important role. Now here is a lady who is having mitral stenosis dilatation. She had some hypertension due to apprehension on the initial phase. And then the blood pressure appears to settle down to about 110, so maybe she becomes less anxious. But what the operator didn't notice was that the heart rate has gone up. When the apprehension settles down, the heart rate should come down. What happened next was
drawing your attention to time, sir.
5 minutes later, the aortic pressure starts showing paradoxes. If you notice here, the RA pressure was about 10 or 12 here. It has gone up to about 25 here, and the aortic pressure shows. So keeping an eye on the hemodynamics is one of the surest way of identifying complications. And when you're doing this and you have a perforation, your whole attention is on entering the LA and on crossing the mitral valve. Early tamponade is often missed till bradycardia or hypotension occurs. Now, keep an eye on the hemodynamics, or ask your assistant to keep an eye on hemodynamics to detect complications earlier. So hemodynamics is critical for the early detection of tamponade and complications. Here is a patient who has a LA pressure.
Time.
Yeah, just finished. Yeah, last but one slide. Yes, classical mitral stenosis, typical man. Now the V wave is large, but you are worried when the V wave becomes even larger after you dilate the balloon. Here you see the V wave has become Himalayan, it becoming almost 2/3 of the LV systolic pressure, and it tells you that you have probably torn something and produced mitral regurgitation. Therefore, again, as I said, hemodynamics are useful for identifying complications. So in conclusions, ladies and gentlemen, method and interpretation of hemodynamics are critical at each steps of balloon mitral valvotomy. Please correlate hemodynamics with other data, echo, fluoroscopy, and any other information you have. Please watch out for confounding factors like cardiac output, heart rate, blood pressure, fluid status, diuretics were stopped in time, were given in the morning or not. Gradient is often used to do serial dilatation. Watch out for signs of hemodynamic complications. And finally, please assess the result of BMV by pressure data when your catheter is still in the LA and you have a catheter in the LV. Thank you very much.